Now, welcome everybody. Welcome. Thank you for joining in with us. Today we are going to be talking with Chrissy, who is a CRNA, and I'm going to pass this over to Chrissy. She's going to give us a brief introduction about herself, and then I'll let Chrissy start. Chrissy?
Hi, everyone. So a lot of you know me from TikTok. Some of you might have seen me on Instagram. My handle is Chrissy CRNA. I am a certified registered nurse anesthetist. That's what that stands for, which means that I give anesthesia in the operating room. So CRNAs essentially can work either with physician anesthesiologists in an anesthesia care team model, and that's how I work. I'm in an academic medical center, so a lot of our case studies are going to kind of be more centered on that. Or sometimes they work independently too in like more rural areas or smaller facilities, for example. So we'll go over all that today.
Okay. All right. We'll get started. Chrissy, do you want to tell us a little bit about your background, a little bit about your education, like where you went to college and how you transitioned into what you do now?
Yeah. So when I was in college, I was not a nursing major. My first degree was in psychology. I minored in biology and Spanish. I thought I was going to go to medical school, or at least I was thinking I might want to go to medical school. So I took all the pre-med courses, and I did a pre-med internship in Mexico when I studied abroad there for Spanish. So when I was in Mexico, I got to shadow all sorts of doctors in local Mexican hospitals. My paperwork fell through. I was supposed to go to 4 hospitals, and at my second hospital, the paperwork fell through for the other 2 rotations, and I couldn't go any further. So an anesthesiologist felt bad for me, and she just adopted me for the rest of the program, and I hung out doing anesthesia for the next several weeks. So that kind of pushed me on the rest of my journey. When I came back to the US, I graduated. I still wasn't really sure what I wanted to do. I bought an MCAT prep book. I was getting ready to start studying for the MCAT. I had a cousin who was trying to encourage me to go into PA school. She's a physician assistant. So to get like more experience in medicine and figure it out, I got a job as a nurse's aide in a surgery center when I was finishing up my last couple semesters. And it was there that I discovered what nurse anesthetists were. We had one physician anesthesiologist who kind of hung out and was available for emergencies and did a lot of pre-opping of the patients. And then there were CRNAs in each OR. And he was really encouraging to me. He encouraged me to consider going into anesthesia. He helped me shadow the CRNAs in the ORs, and I got a lot of experience there. And then I decided to go back and keep an open mind. And I got my second degree in nursing from Thomas Jefferson University in Philadelphia. It's a 1-year accelerated program. And then I got my first nursing job directly into the ICU at the Hospital of the University of Pennsylvania. So I was really lucky to get a cardiac ICU nursing job, which sets you up great for anesthesia school. And I kind of just kept exploring my options. I still considered PA school, NP school, med school, anesthesia. I wasn't really sure, but after about a year and a half in the ICU, I just knew that I loved critical care and that moment to moment, like instant gratification. And that's exactly what anesthesia is like. So I knew that was the way to go. And I applied and got into UPenn and got my master's degree in nurse anesthesia.
That's great. Could you talk about your current life as a CRNA, like what your typical day looks like, what kind of patients you see?
Yeah, so my day can really vary. Since I am in an academic medical institution, I do tons of kinds of cases. Some days it's something really simple like endoscopy, where we're doing colonoscopies and EGDs, and I might have 10 cases, and my patients might be relatively healthy. Some days I'm in the main OR and we're doing oncologic surgery, and patients are riddled with cancer, and they're cut wide open and they're super sick, and there's all sorts of debulking going on. Some days it's GYN. I don't do cardiac now, but we do have CRNAs who do cardiac at the hospital. They're a special team. Every single day can look different. So some days you might have 1 or 2 cases for the whole day. You might have a 6-hour case. And some days you might have like 10 really quick cases. So every single day looks different.
So as a CRNA, you said sometimes you're busy, certain cases are more extensive than others, but alongside with you, like what kind of, how do other health professionals help you with your job, or how do you help others with what you do?
So The OR itself is a team. You really have to have a lot of good communication with the other healthcare members on the team, and as well as people who lead up to surgery and after surgery. So communication with other members of the team are really important. So for example, surgery. Again, at an academic institution, you have residents, you have med students, you have the attending surgeon. We have my attending physician anesthesiologist. We have to like have all these players in constant communication. The OR nurses, the surgical technologists, it's a lot of different people who are all constantly in communication to get everything all lined up for the patient. Educating our surgeons is really important, like what meds we want our patients to hold pre-op or to take pre-op. That's really like an anesthesia kind of call, I should say, but yet the surgeons kind of control the pre-op instructions. So that's kind of like where our coordination of care.
Great. So it's more of like a team effort rather than just a one person thing in the OR. You're working with everybody, including from attendings, nurses, and everybody to make sure that whatever you're doing is going along well. It's not
Definitely.
Just one person. Yeah. How would you describe your relationship with like the physicians who are working with you? I've heard like there's sometimes there might be issues with that relationship. How would you describe your relationship as a CRNA with the physicians?
Yeah. So for physician anesthesiologists specifically, I mean, I know there's a lot of chatter on the internet about that. If you stay away from forums and you go into the operating room in real life, I think most of us get along fabulously. I would say 99.999% of the time, there's not an issue at all. The challenge comes in where we are both ethically and legally responsible for patient outcomes, right? So like just because the doctor tells me to do something doesn't mean I should necessarily do it if it's unsafe for the patient. So we're both responsible, so we both have to agree. So that's like where you could imagine that headbutting could come in and exist. I can't tell you the last time I've run into that. It's so incredibly rare. The doctors I work with are very skilled and very competent, and I really trust their expertise, and I enjoy working with them. So I can't really tell you the last time I ran into that. Of course, like along the course of my training and my career, yes, that has happened once or twice, but it's definitely not the norm. It's definitely a much more rare circumstance. So for the most part, I think we get along really well. And they're usually happy to see us too. They're usually like, oh my God, I'm glad you're here. I love working with you. It's usually great.
Good. A question that I see in the chat that's good is from Tori, and she's asking, are you with the patient for the whole case when you're doing it, or do you like swap out and take breaks?
Ooh, that's a good question. So there has to be an anesthesia provider with eyeballs on you the entire time. But of course, some cases go on for 12 hours. So yes, we have to take breaks, but we can't just leave the patient. We have to have either your attending anesthesiologist has to come in and give you a break, or another nurse anesthetist has to come in and give you a break. And you have to give like a formal sign out and report and go through the whole patient's history so that another expert provider can keep you safe while we step out of the room.
Gotcha. All right. Another question. Okay, I think we're good on questions. Okay. All right. Chrissy has prepared a very interesting case study. So we're gonna get into that, and I'll let Chrissy present her case study now. Chrissy?
Right, perfect. So let me hit my little share screen button. All right.
And
So
really quickly, we have a link in the chat for the simulation that she's going to be using, and she'll explain more about that. Chrissy?
oh, perfect. I'm glad you linked that. Cool. So before we can jump right into the case study, I just want to go over like a couple things with anesthesia with you guys. So just some basic concepts, just to put it into context for you. So this is the anesthesia machine. This is in pretty much every single operating room. This is what we use to monitor you and to give you oxygen, anesthetic gases to keep you asleep. And there's a ventilator on it. So that's kind of like our all-in-one spaceship that we use. It's the car we drive to get you there. There are 3 main categories of anesthesia, and some of them have like subcategories, but general anesthesia is what you are probably thinking of when I say the word anesthesia. That means you're going completely to sleep in a state of unconsciousness deeper than normal sleep, and you can't protect your airway. So you usually have a device that looks like one of these. I brought an endotracheal tube with me. And if you have an endotracheal tube in, this will go through your vocal cords and into your windpipe and kind of sit right here and come out your mouth. You see these on TV all the time. People are using them like straws. The other one is a laryngeal mask airway, or an LMA. And that's a soft, puffy mask that kind of just sits in the back of your throat. You kind of just pop it in. And that is less invasive. That's only good for shorter cases. Technically, it's not a secure airway. A patient could aspirate through it. So if there's any aspiration risk, they have to get the endotracheal tube. So MAC is monitored anesthesia care. That is also known as twilight anesthesia, and that can cover conscious sedation, moderate sedation, or deep sedation. It means the patient's sleepy, but they could be woken up, and they should be able to protect their airway during a MAC case. I would argue that MAC is one of the harder types of anesthesia, simply because patients, their airways obstruct all the time. If you've ever known someone with sleep apnea, soft tissues collapse when patients go to sleep. And they get in the way, the tongue gets in the way, all sorts of different things can happen. So you have to be really good at keeping the airway open, helping the patient exchange and breathe in and out, while also keeping them asleep and comfortable enough to get through the surgery. And then there's regional anesthesia, like nerve blocks, epidurals, and spinals. And nerve blocks essentially are an injection of local anesthesia that numbs up a bundle of nerves and will numb a portion of the body. That way the surgeon can perform the surgery, possibly with the patient awake or just mildly sedated. Or even sometimes it's just used for post-operative pain control. An epidural is like what you hear about women getting during labor, and that is typically done in the lumbar spine. It can also be done higher up as well for pain control. And a spinal is what's commonly used for C-sections, also knee and hip replacements. It's like a one-time shot of local anesthesia that goes below the spinal cord into the spinal canal. And that more concentrated medication makes them completely numb for about 2.5 hours. So that's, again, a picture of the LMA and kind of where it sits in the back of the throat. And all sorts of different types of endotracheal tubes, depending on the type of procedure that we're doing and how we need to secure your airway. The bendy ones in the middle, the really long bendy one that's shaped like this is a nasal ray, and that's going to go through the nose all the way down into the windpipe. And the short curved one is an oral ray. It's purposely bent so that, like for tonsillectomies, for example, the surgeon can work in the back of your throat and get around the tube easily. This is the typical technique that we would use to put in a breathing tube. So for direct laryngoscopy, we have a blade like this. This is a MAC blade, it's curved, and it goes sort of like around the tongue. You sweep it out of the way, up and over, and you should get a view like the one you see on the screen in a perfect world in a patient with a good airway. Then we pass the tube through the vocal cords, pull out the stylet. Ooh, this is hard to do with so few hands. I need another set of hands. And inflate the balloon to keep it in place. You would hook it up to the ventilator, turn on your anesthesia machine, and tape it up. If we have an anticipated difficult airway or a surprise difficult airway that we didn't expect, we also have a way to do this with a cool little video camera. It's usually CMAC, GlideScope. Those are very popular brands. It's a blade that's shaped just like this, except instead of having just a flashlight on the end, it has a little video camera. And you can see on the screen. It kind of just helps you get around the corner a little better. And another advanced airway technique. Some patients have really poor mouth openings. Some patients we can't intubate normally because it would cause too much neck manipulation, like a patient with an unstable cervical spine, for example. And we might have to do a fiber optic intubation. Those can be done awake or asleep. And I'm going to show you a little 30-second clip of this physician. His name is Michael Balin. This is a clip of his YouTube video. It's actually posted on his son's YouTube account. There's a link here if you want to go see it. And he is going to intubate himself awake with the fiber optic bronchoscope.
And we'll get started again.
You can see the tissues kind of moving. That's the airway, and it's going right through the vocal cords.
Oh, are you going to play the video now? I'm sorry. I thought you were trying to get the video to go.
Oh, sorry. Do you want me to restart the video?
You're good. That's good.
Okay. All right, cool. Did you guys get that?
And we'll get started again.
That was funny. I didn't mean to do that. And last but not least, we have a surgical airway. So this is our last resort. If you were to get into a situation where you can't get a breathing tube in the patient and you can't ventilate the patient, meaning exchange air in and out with a mask, you could run into a situation where you have to place a surgical airway. This is called a cricothyroidotomy, this specific approach. And essentially, if you go right above the thyroid, well, I should say right below the thyroid cartilage and right above the cricoid cartilage, in this little space right here, as you can see on the diagram, you might have to actually put a little hole in there and insert either a tracheostomy tube, an endotracheal tube. You can also stick a large bore IV catheter in there and then try to hook up to it. And you would use a jet ventilator to get air exchange, or use lots of short little breaths by hand ventilating. And that's like your last resort emergency backup plan. I hope I never have to do this. I never have. If you are in a nice big hospital with ENT in-house all the time, the ear, nose, and throat team, usually if you run into the situation, either trauma surgery or the ear, nose, and throat team can throw in a tracheostomy at slightly distal to that site. So usually anesthesia won't have to do this, but it is a last resort that everyone needs to be prepared for. All right, so a huge part of this is managing the airway, which is why I'm giving you guys all this information. Our case studies are not going to make sense without this. So how do I know if a patient's going to have a difficult airway or not? How do I make my plan? We can't just walk around and stick this blade in everyone and hope it works out. Or you could, but it might cause more airway trauma. It's better to guess right on the first try if you can, and then have a plan B, plan C, and so on. So does the patient have a history of a difficult airway? Can they open their mouth wide enough? What's their Mallampati score? That is essentially, if I ask you to open your mouth all the way, stick out your tongue and look at the back of your throat, it should look like class 1 would be ideal. That means it's one indication that you should have an easier time intubating. It's not a set thing, because we have to have let me back up. The more things on this list that check off, the better your likelihood of having an easy intubation. If you have multiple things on this list that do not check off, you're more likely to have a difficult intubation. So if you have a class 3 or class 4 Mallampati score, you're much more likely to have a difficult intubation, but it's not a sure thing. Every now and then a patient surprises me. Your neck range of motion, can you move your neck at all? It's really helpful for us to be able to have your head move back all the way in order for us to get a good view. So if you can't move your neck, you might have to use a video technique, either the fiber optic scope or the video laryngoscope. The thyromental distance, that's this, from here to here. The longer, the better. If it's too short from your mentum to your thyroid cartilage, that is an indication that you're not going to have a lot of room to get the tongue out of the way when you try to take a look. And again, with teeth, we want you to be able to bring your jaw forward. And if you have very long upper teeth, we're at risk for them getting in the way of the blade. And neck circumference is the last one. So hopefully you have an easy airway. All right, so hopefully that was good context for you guys to understand what's going on with this case study here. So I had a whole different case study written, and this just came up this week. So this is a real case study that I just came across. It just happened to me the other day, and it worked out great in the end. So nobody get too anxious. We had a 37-year-old male with muscular dystrophy, chronic respiratory failure on a ventilator. He had a tracheostomy in place since childhood, and he now has a thyroid goiter, and he was presenting for a left thyroid lobectomy. So for those of you who don't know, a goiter is essentially when your thyroid tissue gets hypertrophied and just keeps growing and growing and growing, and that can compress your airway. And that's what was happening in his case. So even though he had a secure airway in place, the mass was getting so big, it was shifting and compressing his trachea below the tracheostomy site and making him feel like he was suffocating. Any position changes, anytime he was tilted to the side, would make the airway collapse completely. So it had to be removed. He also had a history of a right upper extremity arterial thrombosis. So we couldn't use a blood pressure cuff on that side or do any arterial cannulation on that side. Respiratory, he was vent dependent since childhood. His vent settings, SIMV at home, it's not super relevant to this chat right now, but I just wanted to include it for anyone who's nerdy and wanted to look it up later. He had a 4.0 uncuffed shy lead in place, which I'll show you guys a picture of so you can see why that's important. Moderate tracheal narrowing. So that was at the level of thoracic inlet, like down here, like I said, distal to the site. And he also had a history of papillomas and granuloma tissue at the trach site. So he had to get this tracheostomy exchanged pretty routinely. And what happens during his trach exchanges is sometimes tissue gets in the way or it gets stuck, which is a huge concern for us because that can cause bleeding in the airway and make it hard to get a new trach in. So if we take it out, will we be able to get one back in? He also had diabetes on metformin, type 2 diabetes, and the goiter, as I mentioned. Muscular dystrophy with contractures, scoliosis, and a total spine fusion, meaning every single vertebrae of his spine from C1 down to the sacrum had been fused several years ago. So there was no ability to move his head in any direction at all. Like even if we were to get him completely asleep, there's literally instrumentation all the way down. So he was permanently stuck in a position like this. He also had acid reflux disease and a little bit of anemia. So when we took a look at him, we just talked about the airway assessment, almost no mouth opening, barely able to open past the finger breath. Decreased lung sounds bilaterally, that's from being in this position. The severe scoliosis prevents good lung excursion. And since he has no real respiratory drive on his own, he's only receiving positive pressure ventilation. He's kind of in a chronic state of atelectasis, meaning the bottom of the lungs kind of getting, the small airways getting kind of collapsed. His limbs were very swollen and stuck in place. They were contractured. Like I said, no neck range of motion, unable to lie flat or on the side, which are normally all the positions we would need you in to put in an airway. Normally we would need you to be flat. We can, of course, do things sitting up if we have to, but it just adds on more layers to the difficulty. So for this surgery, he had to be under general anesthesia, and all of these things in his medical history made it a little bit complicated. So getting IV access. How do you get an IV on someone whose limbs are kind of stuck in a position and swollen? So we ended up using an ultrasound and getting a little IV in right here. For the airway, how are we going to secure this airway? You cannot really deliver good positive pressure ventilation through an uncuffed trach. Essentially, air will just leak around it and come right back out. So we had to get in a tracheostomy with a cuff, and I'll show you pictures of that in a minute. Muscle relaxants. Patients with muscular dystrophy, you can't, normally when we would have like a concern about placing an airway in a patient, it would be our preference, if we can, to use a short-acting paralytic called succinylcholine, but it's contraindicated in patients with muscular dystrophy. You can't give it to them because they essentially have, oh gosh, how do I get into this without talking about the whole pharmacology of sucks? You could cause a life-threatening reaction where they would get a really, really high blood level of potassium that would stop the heart. So we avoid that medication entirely with patients with muscular dystrophy. If you try to use our other kind of muscle relaxants that are longer acting, that don't cause this response, you would need really, really, really high doses due to changes in the muscle tissue over time and what happens at the neuromuscular junction. So we did total IV anesthesia for him. That way we could avoid it. And positioning, this patient would normally really need to lie flat for the surgeon to get to him and for us to get to him, but we had to keep him in the same position. So to avoid nerve injuries or causing any pressure wounds, we just patted him in place in his natural position with lots of foam and blankets.
Chrissy, really quick, I see a really good question. So in worst case scenario, like what operation would you conduct if like the airway became swollen during surgery? Like how would you?
what would we do?
Yeah.
So that is kind of what happened. So,
Yeah.
I'm going to answer that question right now. It's a really good question. In fact, so I'm glad that you brought that up, because that is our number one concern for this case. How are we going to secure this airway? Not only is it being compressed, but it's also going to be operated on. And we have very limited options here. So what do you do? So we had kind of two main options for securing an airway like this. We had to take out his uncuffed trach, and we had to either put in an endotracheal tube directly into the stoma site. You can slip this right in and have it hanging out the neck. That's an option. Although the one bad news is that it's kind of flimsy and could get turned and kinked when the surgeons are operating, and it could even pop in and out because there's no good way to secure it. Because you can't put it in too deep, the balloon would sit just below the tracheostomy site, and it could kind of pop in and out. Also, he has a really small tracheostomy. A 4.0 is a pediatric size, so we would only be able to get a really, really tiny endotracheal tube as well, which can be hard to ventilate through too, and really easy to kink. So that was not a great option. And our other option was to put in a cuffed tracheostomy tube, which would be the same size as his, but that could also have problems as well, since the airway is being compressed down lower. That's not really getting past the site of compression. So he can still have issues with compression during surgery. So we weren't really sure which to pick. We talked about it for a long time. Me, my attending, we talked about it with the ENT surgeons. We talked about it with the oncologic surgeon. It was a big discussion. We kind of ended up deciding to go for the cuffed tracheostomy tube, because we were concerned that if we switched out to an endotracheal tube and then had to switch it back in again at the end, that we might cause more swelling and bleeding with too many airway manipulations. So we decided to, so here's the pictures of the Shileys. I should have put them against a black background. I kind of regret that now. But the image on the left is the one he came in with. So the Shiley without the cuff and the little 4 holes in it. Can you guys see that? Or it's like a little blurry. Should have had a black background. That is what he had. And that is designed that way so that the patient can speak over it. So this patient was able to talk and communicate. It kind of sounded like soft speaking or whispering over the trach, and he learned how to phone it around. The one on the right is the cuffed one. That's the secure airway that creates a nice seal because it has a balloon in the end, just like an endotracheal tube does. And that seal is what allows us to ventilate in and out. But again, he still had that compression distal to it. We used one of these catheters to do the exchange. They are super long. They're like 3 feet long. It's called a Cook Airway Exchange Catheter, and they're hollow. They're giant hollow straws that you can hook up an endotracheal tube to. It has a little tip on the end that has this shape. I'm sorry, you can hook up a ventilator to it. So essentially, you thread the giant straw through the tracheostomy, and then you slip out the tracheostomy, and then you slip on the new one and pull it out. If at any time you were to lose the airway, if it were to seal back up and we couldn't get it in, we would at least have that straw in the airway in the meantime that we could deliver some air through. So that's kind of like our way to keep it safe and patent the whole time if we ran into bleeding, if we ran into swelling, and if the goiter had collapsed the airway entirely, which is what we were concerned about. So it ended up working like a charm. The trach exchange went extremely smoothly, no bleeding. We did not lose the airway, but we did have trouble during the case. So when we were in the operation and the surgeons were manipulating the airway, there were multiple times when it kept coming disconnected on and off of the ventilator, and I had to be very vigilant and watch what was going on with the ventilator settings. And as soon as my tidal volumes would drop, I'd ask them to please check, hook it back up. Sometimes it'd get twisted, they'd have to untwist it. Sometimes they would just compress on the trachea itself, and I would just lose the ability to ventilate the patient at all, meaning no air exchange in or out, because they had to literally pull the trachea and distort it to get to where they needed to. So in some ways, I actually think in retrospect, it might have been better to have a longer tube. at least it would have gotten past that site of compression. But on the other hand, it still would have been a catch-22. It still could have come in and out and kinked, and it still could have, you know, multiple exchanges still could have caused more bleeding and swelling. So I'm still not really sure if there was a perfect way to do it. But at the end of the case, they got the goiter out entirely. They closed him back up. We woke him up in the operating room. We left the cuff shyly in, and we decided to bring him to the ICU like that and let him rest overnight with it and let all the swelling and bleeding calm down from the surgery. And the plan was for the ENT team at the bedside to change it back to his original trach the next day. My anesthesiologist actually was in-house today, and she followed up with him and said he was doing awesome. So all's well that ends well. It went great. Do you guys have questions about that case study before we get into the airway sim, where you guys are going to make the decisions on how we're going to manage our patient's airway?
Okay, I'm gonna look at the comments to see if anybody has any. Rico said, with that small airway, what's the vent settings for that? Won't you get high pressure alarms?
Yes, that's a good question. Yeah, so for the smaller the airway, the more pressure the ventilator needs to generate to overcome the narrow diameter of the tube. So in a spontaneously breathing patient, meaning the patient's breathing on their own with the ventilator, to overcome a size 8.0 tube, we usually need a pressure support of at least 7. For a 7.0 tube, we usually need a pressure support of at least 10. This patient was getting a driving pressure of about 30 to overcome the tiny diameter of his tube. Although we had him very still on a remifentanil infusion, and he was on pressure control ventilation. So meaning we were deciding when he would take breaths. While all of that was going on with airway manipulation and the essentially squishing of the airway, I was not able to get the ventilator to work for him at all. I had to take him off the ventilator and hand ventilate for the case on and off for about 2 hours. So I ended up calling my anesthesiologist in the room for help several times. Anytime I needed a second pair of hands to draw labs, to hang new meds on my pole, I could not take my hands off the bag and stop ventilating the patient, or else no air exchange was getting in at all. So it was really stressful from that point of view while it was happening. So again, really communicating close with the surgeons and being super on top of his ventilation. But it was, I mean, that's such a great question. Yes, it is challenging. You do need a lot of pressure to overcome that. And with the 4.0s, they're not very stable in an adult size airway. So he's still, you know, the size of a 37-year-old man, but that's a pediatric size cuff tube. So those are very wobbly in the airway, and they don't create a good seal. So if you generate too high of a pressure, it just comes back out the top. So it was definitely tough.
Okay, another question that I see is from KJ regarding vitals. What are the ideal vitals for the cases like this? Can you explain the vitals that you check when you're with the cases like this? So
yeah, great question. So the general rule for almost any patient is you always want to keep their blood pressure within 20% of baseline. So always make a note of what the patient's blood pressure is normally, and we want to keep it as close to either 20% higher than that or 20% lower than that as possible. I like to be as strict as possible and try to keep their blood pressure almost exactly normal, because a low blood pressure during surgery increases your risk of acute kidney injury. It increases the stress on the heart muscles. It can really decrease the blood flow to your vital organs during surgery if you have a prolonged low blood pressure. So we almost always run a phenylephrine infusion with anesthesia for any patient who's remotely sick, or when we do total IV anesthesia or remifentanil infusion, that's what keeps them very still. It's a very short acting, very potent narcotic. That tends to drop the blood pressure quite a bit. So we almost always run phenylephrine with that. So he had phenylephrine running throughout the case, as well as IV fluids to hydrate. When he came in, he was very, very dehydrated. And as for heart rate, usually we don't see an issue with patients' heart rates unless something is happening. Sometimes if a surgeon tugs on an area, like actually if they tug on an area near the neck or near the eyeballs, it can cause like a vasovagal reflex and cause an acute bradycardia where the heart rate drops out of nowhere. So you have to be aware of what the surgeon's doing. And if the heart rate drops, tell them to stop and treat it potentially medically if that doesn't resolve it. If you see the patient's getting tachycardic, which did happen to our patient, his heart rate started going up and his blood pressure started going down, you know he's probably going to need some fluids. So there was a little bit of bleeding going on. We gave some fluids, it resolved. Sometimes a high heart rate can be a sign of pain or not enough anesthesia. So those are all the things we're looking at. We watch your carbon dioxide levels, what you breathe out. We can monitor that. And that tells us that you're not only ventilating, but also perfusing. Our oxygen levels, of course, are probably most important in a case like this. And we had a really close eye on the SATs the whole time, but we want to get ahead of treating that and making sure the patient's airway is good before the SAT drops, if we can.
Okay, thank you for that. There's a lot of questions here, but I'm gonna pick one more and then we can get going. How long? So this surgery was kind of involved. How long was this case ended up being with?
That's a good question. I gotta think back and remember. It started. It's a long case. It was probably 2, 3. By the time I dropped it, but from the time that I brought the patient in the room to the time I dropped off in the ICU, it was about 4 hours.
It was a 4-hour surgery.
Yeah, the surgery itself was probably only 3 hours, but getting set up with the airway and transporting out of the room was also very complicated and time consuming. So the surgery itself was probably 3 hours, but we were managing him for about 4.
Okay. Okay, guys, we're gonna get moving. Your questions are really good, but we have to get going. Chrissy has very involved simulation that she's gonna have you guys go through, so I'm gonna let her continue on the case study.
Okay. So, well, that's all I have for the case study. If you guys are good to get into the simulation. Are you guys ready for it?
Yep. For the simulation, we can go into the simulation.
Cool. So the simulation, I'm gonna take some pauses during it. And I want you guys to feel free to, well, I'll be asking you guys questions about how you think we should manage the patient. So let's start out. This is our patient, Hassan. He's 27 years old. He's male. It gave us his height and weight, which is helpful for deciding drug administration. He recently received 3 milligrams of morphine at 5:36. He came in with severe knife wounds to the arms and torso. We think he might have a full stomach because he just got into this, I guess, fight or assault on the street. He is getting a liter bolus of normal saline rapidly infused because his blood pressure is low and he has an IV. Our goal is to sedate him and secure the airway so that he can continue to surgery. So this simulation was designed to, I believe, originally train military personnel. So this is more of a setting of like what you might see in a MASH unit in the field. Some hospitals, actually most hospitals in the UK do anesthesia similar to this as well. They will stabilize the patient and get the airway and then bring them to surgery in a separate room. And in emergency rooms across the country, ER physicians routinely put airways into patients and do this portion. So if you're interested in emergency medicine at all, this is something you would see in an ER. For anesthesia, of course, this is not an operating room, so this would kind of only be leading up into securing the airway. We're not going to get to see what would happen during surgery. All right, so that is his chart, and then let me know if you need me to go back to anything. So let's start assessing this gentleman. We're going to look at his airway first. We're going to look from the side. I'm not going to be able, actually, it does let me get his mouth opening. So here, I don't have his head or neck fully extended. I can't make the simulation let me do that. But it looks like he has a decent thyrometric distance, which is a really good sign. Same thing from the other side. Having a beard in place is definitely a challenge for us to get a good seal when mask ventilating. The air tends to leak out around the beard. So I don't like that. When he opens his mouth all the way, normally he would be sitting upright and we would look head on, but that's okay. He has a really great Mallampati score. You can see the whole uvula maxilla, the hard palate, the soft palate. It doesn't look like his teeth are going to get in the way. He has a really wide mouth opening. So I really like his airways so far. Okay.
It's getting difficult. Oh, yeah. I've been trying to say, it's been really difficult to hear you. Can you mute the simulation so I can hear you clearly?
Oh, sure. I didn't think it had sound on it.
Yeah, that's better.
Ugh, that's so weird that it's doing that. Options. There we go. Sorry, guys.
Yeah,
I'll start over.
I was trying to tell you, but I think you couldn't hear me over the voice, but that's okay.
I still can't hear it over this. Look at this. This is terrible. It's still, I don't want any sound. Is it still loud for you guys?
Yeah, it's very loud.
Oh my God, this is terrible. Whenever I pause it, it works. This is so silly.
Yeah, there you go.
Is that better?
Yeah, if you could lower all of them down. Perfect.
I mean, that's me muting you too, but does that still work?
No, it started back up again, even though you did it.
Yeah, it's still kind of loud. Yeah, everything's down all the way.
Okay, yeah, that's better.
Okay, let me know if that happens again. Sorry about that.
It's happening again. Oh.
Yeah, I can mute my speaker, but then I won't be able to hear you at all if you have to chime in.
Okay, I will just say anything if I can just say anything if I want in the computer. In the chat on the Zoom. So if you can just mute me and
Perfect.
monitor the chat, okay?
All right, let me do that. Okay, here's the. Okay, here's the chat. Hi. Perfect. All right, guys, let's start again. Sorry about the technical difficulties. Is everybody good now? All right. So this is our patient, Hassan. This is supposed to be like, I think this program was originally designed to train military personnel. It's free if you want to try it out yourself. There's a lot of different sedation and airway scenarios. It only works on a Windows computer, unfortunately. So if you have a Mac, it won't work for you, but it's called the Sedation and Airway game. So essentially, this is supposed to be like an ER type of environment or a MASH unit in the field, but it's still going to give you a good picture of the kind of decisions we have to make when securing an airway for surgery, even though you won't see the surgery itself. So Hassan has suffered severe knife wounds to his arms and torso. He is a suspected full stomach, meaning he probably ate today. He is getting a liter of normal saline, IV fluids being rapidly infused. He does have an IV. He was recently given 3 milligrams of morphine for pain. And he, let's see, is 27 years old, and you have his height and weight here. 84 kilograms will help us decide how to administer his medications. Can you guys just let me know in the chat if you can hear me? I just want to make sure I'm not talking to myself again.
It's much better now. Yeah, I can hear you properly, and then.
Or if you can.
Yeah, can you hear me, Chrissy?
Can you hear?
Oh, I gotta go.
Can you hear me right now? Is it working?
Yes.
Okay, good. All right, so I'll keep going. Perfect. All right, so let's get boogieing. So let us look at his airway all over again. So first things first, we are getting a side view here so we can look at his thyromental distance. That is from the tip of his chin to that thyroid cartilage there, thyromentum. And it looks like he's got a nice long thyromental distance. Same thing on the other side. I don't see any deformity, anything abnormal. If we have him open his mouth all the way, and this is supposed to mimic a Mallampati score. It's not perfect, but he has a nice wide mouth opening, and it looks like he has a Mallampati class 1, meaning we can see his uvula, his hard palate, his soft palate. I don't see any protruding teeth. I don't see anything that looks like it's going to get in the way. So I anticipate that he should be relatively okay to intubate. The only thing I don't really like here is that he has a long bushy beard, and that will get in the way of getting a good mask seal if we want to ventilate him, meaning squeeze the bag and use the mask. So I'm going to ask you guys this. What do you think the airway plan should be? We have to get his airway secure for surgery, and we think he might have a full stomach, meaning he's at risk for vomiting. So I know I kind of blazed through the airway techniques, but can someone respond on YouTube and let me know what you think our plan A should be for getting his airway and what our plan B should be?
Give it a second. We'll give it a few seconds for somebody to say in the chat. A little behind.
And I'm going to wait to see what you guys have to say.
Yeah, I'll let you know if I see anything.
Now, I should probably read out what these options are. Let's see what that says.
Okay, so I see ETT.
Yeah, so I think the picture of the lungs, okay, here it is. Primary plan, natural breathing with supplemental oxygen, so just breathing on his own, a face mask, nasal trumpet, oral airway. This is intubation, so what I showed you earlier, and putting in a breathing tube. LMA, it's the other way to administer general anesthesia. And the other one is cricothyroidotomy, so it's the surgical airway. So what is everyone's plan A? Do we think that he needs a secure airway, or can we have him breathe on his own?
I think I know the answer, but I'm going to let somebody in the chat say it.
And it's okay if you're wrong. And I'll give you guys a hint. We mentioned earlier that he does have a full stomach.
Okay, so we're saying secure airway. A lot of people are saying secure airway, intubate.
Perfect. Okay, good. So we do have to intubate. That's our plan A. What's our plan B if that doesn't work out? We always need at least one backup plan in anesthesia, but we usually have 2 or 3.
We'll give it a second. Mouth, CCAP, use a different type of intubator.
Okay, that's true. Actually, you know what? The scenario doesn't give us that option, but yeah, absolutely, if a direct laryngoscopy did not work out, my second choice would definitely be the video scope. My third choice would be the fiber optic scope for getting a secure airway. I'll let you guys know that even though we don't love laryngeal mask airways when the patient's at risk for aspiration, if you're in a desperate scenario and you can't get a secure airway in the patient, the LMA is usually our next go-to as a temporary measure until we can try something else. There are intubating LMAs where you can actually slide an endotracheal tube through the LMA with the help of a fiber optic scope. So that's probably what I would do as my second plan, knowing that the patient could aspirate through it. but it would be better than him not getting ventilated at all. So I'm going to mute this function again, but our primary plan is to intubate with a direct laryngoscopy. Our backup plan is LMA. I really don't want to do that though. Our last resort plan is always cricothyroidotomy, but I really, 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 really don't want to do that one. All right. So let's select that. So intubate and ventilate, use an endotracheal tube size 7 or 8, and laryngoscope plate size 3 or 4. That sounds good to me. And here is the LMA, even though I don't actually want to do that. But if I have to, I will. Okay. Now, well, let's just take a look at his vital signs in the top left corner. They really don't look so hot to me. A normal adult blood pressure is what, 120/80? So 65/45, that tells me he's bleeding, especially with the high heart rate. And we know that we have chest wounds. He could be bleeding into his chest wall right now or into his abdomen, and we wouldn't be able to see it necessarily. So that is not such a hot blood pressure. When we give anesthesia to put him to sleep, it's going to drop his blood pressure even more. So I want you guys to keep a really close eye on his vital signs while we are performing the procedure. So let's get some drugs ready. In anesthesia, we always draw up all of our sedation medications, but also we have ready to go lots of different emergency medicines. So in an everyday setup, you pretty much would usually have some fentanyl. It's a pretty typical opioid to put people to sleep with. Works quickly. It has a peak onset of about 5 minutes. I'm going to make these little mini syringes. The way that this scenario works is you can only give the total syringe at once. So I'm just going to draw up small doses. In real life, we would have a big syringe and we just give it more. 2 different medications that could keep the blood pressure stable or even improve it. Well, etomidate would keep it stable. Ketamine might actually raise the blood pressure when putting him to sleep. So we could use either of those. Propofol will put him to sleep. That's our most common drug for inducing anesthesia, but it will tank his blood pressure further. So I'm not even going to draw up propofol today. I'm feeling like etomidate. We don't get to use it a lot in real life. It's not really great for that many patients, but let's do it. Let's just be wild and use etomidate. Phenylephrine, we're going to need a lot of this. That is going to bring up his blood pressure, and it will not raise his heart rate. Ephedrine raises the blood pressure and the heart rate, and I really don't want to raise his heart rate any further. But he's young, and he probably does not have significant coronary artery disease. So if his heart rate has to be a little bit high, he can probably handle it. He is going to go right into surgery, so I am going to just go straight for a longer acting muscle relaxant, and we will sedate him afterwards. We could use succinylcholine, but if we use a rapid sequence intubation dose of rocuronium, there will be less of a risk of him just kind of like coughing and bucking on his way to the OR. Let's see what else. We should probably have epinephrine available. We'll just give little baby doses at a time if we need it. We can always grab more drugs from our drug box if we need to. Have 0.5 of atropine available, just in case his heart rate drops. I don't think it will, but just in case. Okay. So his blood pressure stinks. We got our drugs ready. Let's take care of him. All right. I'm just going to check in quick, make sure you guys are good. Is everybody good right now?
Yeah.
Oh, that was too loud. All right, so just to recap on him, knife wounds, full stomach, our plan is to intubate. He is getting fluids to treat his blood pressure, but doesn't seem to be doing enough yet. We are going to, let's check his lung sounds really quick. Patient breathes out, breath sounds are normal. Patient breathes in, breath sounds are normal. That's that little text on the bottom of the screen. And we'll check the other side, the left lung. Patient breathes out, breath sounds are normal. Patient breathes in, breath sounds are normal. Okay, good. So he likely does not have a pneumothorax, meaning a collapsed lung. And this is the vital screen. So vitals are still the same. They still stink. In real life, we'd be moving a lot faster than this. All right. So let's get back to the patient. Let's see how awake he is. Okay, so if I said, can you hear me? And he said, mm-hmm. So he's still very conscious. So we're going to talk to him. We're going to say, hey, we're going to get you off to sleep, sir. We're going to position your head. Let's get him in a good position to intubate. We want him in the sniffing position. That increases our chances of a successful intubation. So I tilted his head back a little bit and put it up on a pillow. Because he is at risk for aspiration, he has a full stomach. When we go off to sleep, we're going to apply cricoid pressure. That means that we're going to have a second provider, whether it be a nurse, the anesthesiologist, the surgeon. Someone is going to take their hand and hold down this cricoid cartilage and push it down and smush it to kind of collapse the esophagus. And what that's going to do is help decrease the risk of vomit coming up. There is a debate in the anesthesia community of whether it's worth doing or not, because it's really not based on any evidence. That being said, it can't hurt. It could pretty much only help. So for the sake of the scenario and the high likelihood of him having a full stomach, we're just going to do it. So I'm going to hit the cricoid pressure button. There's no image of a person doing it here, but we click the button so the simulation knows that we did it. Let's turn on our oxygen. In real life, I have an anesthesia machine next to me. I think that's supposed to be the anesthesia machine in the corner. Turn it up, and I would put a mask over his face. This is really an ambu bag or a bag valve mask, but in real life, it would be an anesthesia machine for us. And you can see he's spontaneously breathing. He's pulling on the bag and making it go up and down. We are not ventilating him. Okay. So because his blood pressure stinks, I'd like to fix it before we move forward with putting him to sleep. So let's give him a little bit of phenylephrine and see what happens. You can watch his vital signs in the top left corner, right now at 60/43. Restart the scenario. Oh my God, what a nightmare. We'll zoom through it. That's a shame. Why did that happen? I hate technology, you guys. I just wish you could come into the OR with me for real.
Oh.
We're just getting to the good part. I'm wondering if I should just X out and start again. Let me turn on the volume in the meantime. Ah.
Chrissy, can you hear me?
Let's close the program. I don't want to report that to Microsoft. Okay. Perfect. All right, so we assessed his airway. I just got to drop the drugs again. That's the only thing that's annoying. That's okay, because you know what? In real life, weird stuff like this happens too. In the OR, someone could steal all your medications for another emergency procedure, and then you have to really quick drop new ones. That happens. Hopefully not too often. That would be pretty mean. Just do 50 of fentanyl. Okay, I think that's all we're gonna use. All right, and we gotta select our airway plan again. Okay. All right, so let's get this gentleman off to sleep. So let's turn on the oxygen again and have a nurse or our anesthesiologist or surgeon check the pressure. And we're going to start giving him his oxygen. His blood pressure still stinks. So let's give him some drugs. Did I not drop phenylephrine? That's the one I want. Okay. So phenylephrine is going to bring up the bring up the blood pressure, but not the heart rate. So I'm hoping that that will work and give us a bump. In real life, we would get multiple large bore IVs and give him lots of fluids right now and probably be starting blood too. But the simulation is limited and we have on hand of drugs. And you know, fluids are not an immediate fix and they're not an absolute fix. In real life, you would definitely have to use both. Okay, good. So he's gotten 200 micrograms of phenylephrine total, and his blood pressure is more compatible with life. I like that a lot better. As a young man, thankfully, he can probably tolerate the low blood pressure a little bit better than an old person would. So that's helpful for us. It's still not perfect. We're still going to be, oops, I didn't want to give uranium. I wanted to give phenylephrine. There we go. Okay. So we'll give him another little boost. I noticed the heart rate came down a little bit. That's because he has an intact baroreceptor reflex. Essentially, your body has something called baroreceptors in it. They're located in the aortic arch and the carotid bodies, and they sense blood pressure changes, and your heart rate responds to those. So when you rapidly increase your blood pressure, your heart rate comes down as part of that reflex. So let's get this gentleman off to sleep. I'm not going to give him any extra narcotics or anxiety medications before intubation because his blood pressure is so low. A little squirt of phenylephrine. And we're going to go slow and give him etomidate because that will keep his blood pressure stable. The other option would be ketamine. I think either one's appropriate here. You would give a really, really, really high intubating dose of ketamine. So let us... And the other thing is we would have suction available. Oh, you know what? His head's not positioned anymore. Let's fix that. There we go. I knew that didn't look right. Okay, perfect. So let's give some of that etomidate and see what happens. I'm watching his eyes. I'm watching his vital signs. I'm watching his chest excursion. We could see his chest expanding as he's breathing. He still looks like he's breathing. He's still pretty awake. Let's talk to him. Can you hear me? So he's wide awake, which is shocking because that would put most patients to sleep right away. So let's do another, I'm not going to give that much more. Let's give another 10 milligrams of etomidate. I don't think in real life that would actually be an issue, but who knows? Every patient's different. Okay, he looks like he's starting to fall asleep. Maybe I just wasn't patient enough. In real life, you know, it'd probably take like about a minute to peak. So maybe I'm just rushing through this. I don't know how accurate the sim is. Let's see if he can hear me. No response. Tap his shoulder, make sure he's really asleep, no response. And sternum rub, no response. Now in real life, this is a very time-sensitive issue. I don't think I'd really be checking all that much. As soon as his eyes were closed and he was drifting off, we would probably give the muscle relaxant. Let's give him a little more phenylephrine. I see that blood pressure is still going down. The laryngoscopy itself is stimulating. It will hopefully bring his pressure up. And we're going to paralyze. So the rock will take about 60 seconds to kick in. So right now there is still a nurse or surgeon or anesthesiologist holding cricoid pressure. We would not be ventilating him at this point in real life. We would just let passive oxygenation happen. Squeezing air in and out of his chest would increase the risk of aspiration. After the rocuronium peaks, let's keep giving some phenylephrine. I really don't like that blood pressure. We are going to be ready to intubate. So let's take the mask off and get ready to intubate. So we already talked about our intubation techniques. I think most people like using MAC blades on adults, and that's what I'm comfortable with. That's this thingy here. And look, we have a grade 1 view of his vocal cords. So let's get that tube in. Over here, you can see I'm passing it through the vocal cords. Depth of like maybe 23 centimeters. We're going to inflate the cuff. That's that little balloon here. And that way it's nice and secure. And then we need to hook it up to this and start assessing to make sure it's in before we do anything else. That's not the button I wanted to hit. I wanted to see, check the airway. So let's see if we want to see if there is condensation in the endotracheal tube. That's a sign that we're in, and I see some. I see color change on our end tidal CO2 monitor. So when there's carbon dioxide present, it goes from purple to gold. I also see chest rise. Let's take a listen to his lung sounds. Patient breathes in, breath sounds are normal. Patient breathes out, breath sounds are normal on the right. That's a good sign. I see his chest rising up and down. And let's see the left. Patient breathes in, breath sounds are normal. Patient breathes out, breath sounds are normal. So that tells me that the tube's not in too deep. If it's too deep, it tends to migrate into the right main stem bronchus, and the breath sounds will be louder on the right than the left, or they might not be present in the left at all. We are going to secure the tube in place with some tape. He's intubated. Let me just make sure that Zoom chat's not gone. The problem is his blood pressure still stinks. Big time. Oh, and we can release cricoid pressure now that that's in as well. And that medication's not working, so we're going to give some ephedrine, even though it's going to bump up his heart rate. All right, so in real life, we would keep working on his blood pressure and get him to the OR. It looks like his sats are dropping. Let's figure out why that's happening. I notice his SpO2 is down to 86. So we need to assess again the airway. Let's take a look at his lung sounds. So the right sound's okay. And what's going on with the left? There's no breath sounds on the left. Okay, so we gotta fix that airway. So let's unsecure the tube, deflate the cuff, and look, it migrated all the way to 30. So let's pull that back to 23. I don't know how that happened, but maybe somebody threw like a blanket on the patient. I don't know. They did something bad. Let's reinflate the cuff, secure the tube, and check again. Oops, I gotta hook the oxygen back up to him. Okay, so we have breath sounds restored on the left again. We still have condensation in the tube. And that's it. We fixed it. All right, guys, I think we're done. Let's see how we did. So we completed a good airway management plan. We turned on the oxygen. We remembered to do cricoid pressure. I gave him medications for his blood pressure. It was proud of me for giving ephedrine. We intubated appropriately, but I let his sat drop low, so I identified the right main stem too late. Ooh, I guess I forgot to reapply cricoid pressure when I was re-advancing the tube. It's telling me I incorrectly intubated the patient. I think I just clicked something, but that's okay. All right, let's get out of here. Let's go back to Zoom. I just want to hit stop share. Cool.
Hey, Chrissy. Okay. That's about time, Chrissy. Thank you for going through the simulation. I'm gonna look at the chat one more time to see if anybody has any follow-up questions.
Yeah.
But that was really cool.
Oh, I'm glad you liked it. It was hard with the sound issues to get it to be as interactive as I wanted, but I hope you guys still liked it. Feel free to ask me some questions and I'll try to get through them quickly.
Yeah, it looks like we have no questions. So we'll wrap it up then. Chrissy, thank you so much for coming and taking your time to go into the simulation and the case study. And I think everybody really enjoyed it. A lot of people had a lot of questions. So I appreciate that you took the time, and the audience does too, for coming in. So that is it, guys.
Awesome.
If you have any other questions and comments, please go on to our official Instagram post, official Instagram. It's at Official Club Med. And you can follow Chrissy. She's very active on her TikTok. Chrissy, would you tell me what your TikTok is? I'll put it in the chat for the people so they can follow you and watch your videos.
Sure. It's just Chrissy CRNA. It's the same on Instagram as well. So if you guys had questions about that we didn't get to answer due to time and technology, feel free to direct message me on either platform, and I'll be happy to do it there.
All right, I put that in. All right, be sure to follow Chrissy on our TikTok and Insta, and thank you, everybody.
Thanks, guys.
Yep. Bye, Chrissy. Thank you.
Bye.